Hello friends, today we are going to see the management of prostate cancer. If you go through the Campbell and Wall's urology, the treatment of prostate cancer, it will be a very vast subject, and after reading all the management options, it will be very difficult to come to a conclusion. So in this video, I'm going to teach you the management options of prostate cancer in a very simplified manner so that you can able to understand it better. Before venturing into this video, you want to know about the TNM staging of the prostate cancer and some basics about the treatment of prostate cancer. Here in this video, we are going to see only the algorithm. Okay, so coming to the treatment of prostate cancer. Let us first see the treatment of non-metastatic prostate cancer. Non-metastatic, asymptomatic, symptomatic prostate cancer. Okay. First, we want to differentiate whether the patient is having metastatic prostate cancer or non-metastatic prostate cancer. Okay. This is the first question. Okay. Whether metastasis or non-metastasis. Non-metastasis. The next question is whether the patient is candidate for curative treatment. Okay, whether the patient is a candidate for curative treatment. If the patient is not a candidate for curative treatment, and that means the patient is a very frail patient with the ECOG status more than 2, and especially the life expectancy of these patients will be less than 10 years. So in these patients, we want to give faithful watching. Okay. And the other scenario is the patient is amenable for curative treatment. So after this, we should ask a question whether this patient who is amenable for curative treatment is opt for active surveillance or not. Okay. Before going into this, we should know what are the indications of active surveillance. So the indications are low risk disease. I will come to the risk stratification later. Low risk disease, and if the patient is having a grade group, ISUP grade group 2, and less than 3 course positive, and or less than 50% of the core involvement by the tumor. The patients who are opting for active surveillance should not have an intraductal carcinoma in the histopathology or a cribriform variety in the immunohistochemistry. Okay, cribriform variety. And the patient also should not have a grade group of 3. Grade group of 3. That means 4 plus 3. Okay. So these are the indications for active surveillance. If the patient is opt for active surveillance, then you can give active surveillance. No problem in that. Okay. If the patient is not suitable for active surveillance, means we should want to stratify the patient into low risk, intermediate risk, and high risk. High risk. High risk also include locally advanced disease. Okay. In NCCN, the intermediate risk is further classified into favorable and unfavorable. Okay, the risk stratification is based on PSA, grade group. In low risk, the PSA is less than 10. Okay, intermediate risk, the PSA is 10 to 20. In high risk, it is more than 20. And the grade group here is less than Gleason score. Okay, coming to the Gleason score, that will be easier for you. Gleason score is less than 7. Here it will be more than 7, and here also it will be more than 7. Next comes the TNM staging. Here up to T2A, that is um, one half unilateral one half involvement by the tumor. Here it will be more than T2B. Unilateral involvement more than one half. Okay, here also it will be more than T2B. Locally advanced disease means T3 or more disease, and if the patient is having a nodal positive cancer. Okay, so according to this, um, I want I want to tell you what is unfavorable category also in NCCN classification. It involves more than three cores positive, more than 50% involvement of cancer in the core, and Wilson's group 3. Okay, this comes under unfavorable. In favorable, there will be less than 3 core, less than 50%, and Wilson's group is 2. That is ISUP group is 2. Then we categorize the patient into um, low risk, intermediate risk, high risk, and locally advanced cancer. Low risk tumor, as I have told before, you can go in for active surveillance. Okay, intermediate risk. What are the treatment options available? Okay, we know mainly the treatment of prostate cancer has three treatment modalities. One is the surgery, that is radical prostatectomy with extended inguinal lymph node dissection, pelvic lymph node dissection. And second is radiation therapy, and the third is androgen deprivation therapy. And the fourth is systemic chemotherapy. Okay, so these are the options we have. So in the intermediate risk patient, um, the treatment options are radical prostatectomy plus or minus extended pelvic lymph node dissection. And the next treatment option is external beam radiation therapy plus androgen deprivation therapy. That is 4 to 6 months, short-term androgen deprivation therapy. You can also give low dose rate, low dose rate brachytherapy, okay, or along with ADT, okay. You can also give high dose rate or low dose rate brachy plus external beam radiation therapy. Here also external beam radiation therapy. One thing to note is that this brachytherapy should be given with external beam radiation therapy. Okay, so high dose or low dose brachytherapy along with external beam radiotherapy along with ADT, that is short time, 4 to 6 months. Okay, this boost can be given for unfavorable intermediate. Okay, so come next we are going to see the high risk group. So what are the treatment options available? And high risk, a radical prostatectomy can be done along with extended pelvic lymph node dissection. This, most of the time, this is a part of multimodal therapy. Multimodal therapy. The other option is the same like external beam radiation therapy plus ADT, that is long-term ADT. Long-term ADT means 2 to 3 years. External beam radiotherapy can be given up to a dose of 76 to 78 gray. This is without hyperfractionation. Okay. So brachytherapy also can be given like a high dose rate brachytherapy or low dose rate brachytherapy boost to the external beam radiotherapy plus ADT, that is 2 to 3 years. We can also give abiraterone to this high risk group. Okay, abiraterone. It is given along with prednisolone because to prevent hyperaldosteronism. Okay. So abiraterone should be given for 2 years. So what are the patients in the high risk group you should consider giving abiraterone? Includes patient with a T3 or more, and PSA more than 40, Gleason grades 4 and 5. Okay, these are the indications for giving abiraterone in high risk group. Next, we are going to see the locally advanced prostate cancer. So, locally advanced prostate cancer. So, what are the treatment options available? Here also, if possible, we can do radical prostomy plus external pelvic lymph node, extended pelvic lymph node dissection as a part of multimodal therapy, or ADT, that is long term, 2 to 3 years, plus external beam radiotherapy. If you have a brachytherapy, that is low dose rate or high dose rate brachytherapy along with external beam radiation, it's the same like high risk group, plus androgen deprivation therapy 2 to 3 years. Okay, for node positive patient, what should we do? Okay, here also, if possible, we can do radical prostatectomy plus extended pelvic lymph node dissection as a part of multimodal treatment, or external beam radiation therapy, including the pelvis, whole pelvis radiation therapy. Okay, the patient is having a node positive disease, you should give radiation therapy to whole of the pelvis. Okay, plus ADT, that is 2 to 3 years, preferably to give, it should be given for 3 years, plus abiraterone plus prednisolone for 2 years. So here you can see like the abiraterone is given in high risk group when the patient is having a PSA more than 40, more than or equal to 40, T3 or more, and Gleason's grade 4 or 5, and when the patient is having a node positive. In these cases, consider giving abiraterone for 2 to 3 years. So till this video, what we have seen, first of all, if the patient comes to you, you should first ask the question whether the patient is metastatic or not. And the next question will be whether the patient is amenable for curative treatment. The next question will be whether the patient is suitable for active surveillance. The fourth should be to risk stratify the patient, risk group. And according to this, you can plan for the treatment. In the next video, we are going to see the treatment of metastatic prostate cancer. Thank you. Thank you for your patience.